Okay, Dr. Lee, thank you so much. We'll turn it over to you now. Thank you.
All right. Welcome everybody. I'm so happy to be here. Thank you very much for the invitation. I'll kind of give a quick uh, background. And I would say that my life has been full of ironies. That's the best way I can kind of describe things. I started out as a aerospace engineer, working for a company that a lot of people don't remember, McDonnell Douglas, part of the space shuttle program. And when that kind of went defunct, I had a choice of either becoming a teacher, which is very noble, or going to other academics. So somebody told me I should apply to medical school, so I did, and I didn't really know anything about medical school. I didn't have any friends who went into it, and my mentors basically told me I had to take this specific path. And so I'm actually fellowship trained in neuromuscular disorders, epilepsy, and movement disorders specialty. So did all of those things. I'm currently practicing in Northern California. We're part of a medical group called the Permanente Medical Group, or most people know it as Kaiser-Permanente. So today, I really wanted to go over kind of the background of dystonia and then talk about how do we navigate and empower our patients. What I think it's a little challenging creating a presentation because many people have different they're in different aspects of their journey. So some people may have just gotten the diagnosis, some people may have been living with it for 30 plus years. So what I try to do is I try to balance things out, and at the end, if some things are a little unclear, I'd be happy to answer in more depth. So, I wanted to go over the objectives because this will give you kind of a a a glimpse into what you'll expect today. We'll start with the taxonomy and the physiology and the definition of dystonia. And I start there because I think sometimes in the rush of patient and physician or provider discussions, um, this type of thing may not be discussed in depth. And maybe our patients are not aware that we think about these things. And then I want to go over what to do when you go to a doctor or a provider. Because sometimes you want to tell the physician or provider everything and anything, but I'll kind of touch on key things that your provider may want to know. And then we'll go over testing and the utility of testing, and maybe it is required, maybe it's not. And I kind of go over the details of that. And then we'll touch on current state of treatments. And then, and I will also talk about briefly about the future and what future treatments may look like. And then, I want to go over navigating healthcare. I'm sorry, the numbers are, the auto numbering kind of get messed up there, but that's number 4, navigating healthcare, because I think one of the challenges anywhere in the world, when somebody gets a diagnosis, number one, sometimes it's very shocking. It's you're hearing terms that you've never heard before, and then you have to ask yourself, well, what do I do next? Is there going to be somebody else that will take care of all of this for me, or do I have to do everything? And what I want to do is I want to make sure that all of our patients understand options, and we want everyone to be the stewards of their own health and advocate for yourself. And obviously, family members can also advocate, but in the end, you will be making the decisions, and you need to make sure you make an informed decision by understanding every aspect of the kind of the maze of healthcare. So those are the things that I'd like to go over today. So let's talk about sorting movements. Now, again, this is something that usually physicians, neurologists will not really talk to you about. And when somebody comes to the office and a patient tells me something, something, something is happening, in my mind, as a movement disorder doctor and a neuromuscular doctor, I kind of strategically figure out what my patient is telling me and try to categorize it in some way. And so you don't have to read all of this, but you just have to be aware that, and sometimes we have to say, please give us the benefit of the doubt. We are thinking about all of these things when a patient presents with certain symptoms. And going into a little bit more detail, we sometimes categorize things as jerky movements or non-jerky movements. And dystonia is categorized under non-jerky movements. And I'll go over the definition a little bit. I mean, this is kind of the simplistic definition. This is the definition that you'll read when you look it up on a search engine, or maybe, in the rush of things, the physician will or the provider will describe it in this manner. But my hope is to go into a little bit more detail. I want to talk about these terms. I put primary and secondary dystonia in quotes. Now, the reality is there's no such thing. And some physicians may not use these terms, but the way that I categorize things, I look at it from kind of the perspective of the inciting factor, the thing that may have triggered the reason you're in my office. You can kind of think about things like primary dystonia. So if you think about children, if they have a genetic disposition for dystonia, maybe they have a mutation called like DYT1, generalized dystonia. I consider something like that as primary dystonia. Secondary dystonia is something like if you had a stroke, or you had, you weren't meant to have dystonia, but something happened to trigger it or to amplify it. So you may have had a stroke. You may have had traumatic brain injury. You might have had another illness that could have triggered or amplified something like this. You might have been exposed to something, right? These are the things that we think about when I say, quote unquote, secondary dystonia. And I won't go into all the details, but I think, as part of this support group, you may be aware that there are all these, specific or descriptors of dystonia. And, this is okay for us to describe kind of in a rushed environment. But this is not, ironically, this is not as simple as that. So just briefly about history, we have known about dystonia. We may not have used that term, but we have known about these symptoms for a very long time, and we can see it reflected in art. The art piece that I really like is the one that you see on the right, the girl with red hat. And you can see that clearly, this artist wanted to depict cervical dystonia. And what I like about this is on top of that, that finger that you put on that chin is our sensory trick, right? It's the sensory trick that some of our patients use to try to keep the head straight. And so this is 1893. And you can see in the middle, 1642, the boy's right hand. You can kind of see how it's the dystonic posturing there. And so we have known about this, but it hasn't been very long where we were able to identify and characterize dystonia. Now, this gets into a little bit more complicated detail. And again, I put this in here not because I want to explain this, but I do want to make sure that our patients understand the reason why dystonia could be complicated is because this is inherently a disease of circuitry, okay? This is a programming problem. And there are these, what we call nested loops. So these are circuits that reside in various levels of the nervous system. So we have higher control circuits, and that's typically something that we think about going on in the brain. But the brain stem circuits, that's a little bit below that, are also involved. Circuits in the spinal cord, circuits that connect the spinal cord to the muscles are all involved in dystonia. And dystonia can arise from every one of these levels. And dystonia can involve two of these things, three of these things, one of these things, or all things. And so that makes it really challenging for physicians and scientists, because we are not talking about, hey, there's this one thing in the brain that's malfunctioning. We used to think that about 50 to 60 years ago. We used to describe dystonia as, well, we think that what we call basal ganglia, an area of the brain, is the end all be all. That's where everything is happening. And if you fix that, everything's going to go away. That is not true. That is absolutely not true. And I will show you why. And hopefully during the question and answer, I can elaborate on that as well. But I just want you to be aware that these things exist. Now, when we talk about definition, I kind of gave you a glimpse into the simplistic definition. This is the thing that people kind of throw out there. But for a physician, for a movement disorder doctor, dystonia can be described in various ways. So point number one, I think you have heard this before, where we say, well, it's an involuntary muscle contraction. And depending on where it's contracting, you have some type of symptom. And then if the physician or the provider can characterize it, a couple of slides ago, I talked about things like focal and segmental, and they may be able to characterize it that way. But, there is this, the problem with all of that is that, like I just said, these involve a lot of circuits. And it might be better for us to just say that, dystonia is a disorganization of movement. There's another type of definition that could be characterized by electrodiagnostic data. So I am a neuromuscular doctor who run a electrodiagnostic lab, essentially, in my clinic. And we use an electromyography machine. Now, electromyography, what it does is that it records and listens to muscle activity. When the muscles fire, when the muscles contract, it gives off these signaling. And we record or we analyze these signals. And depending on the pattern of signals, we can predict or diagnose certain types of disorders. And so dystonia can be characterized by very specific electrodiagnostic patterns. And so that's something that is really important in my practice, in order to increase the fidelity, increase the accuracy, precision, and making sure that we are treating the right thing. We want to make sure that we have this right using electrodiagnostic testing. Some definitions talk about alterations of inhibitory circuits. Essentially, what it's saying is, it's like signaling run amok. Things are doing things that it's not supposed to. The fourth one is, again, a little bit of a complicated definition. What they're saying is that, signals are not on and off. The brain is much more complicated than that. And depending on the magnitude of a signal, it's how the system and the circuits are stressed, how stressed it may be, and if that goes awry, then dystonia can occur. And then the last definition is a disruption of visual input or sensory input, and the effect of that on these circuits. So, people always ask, well, why is it that if I have cervical dystonia and I put my finger or my my fist on my chin, why does that fix it? Why does that happen? Well, the thought is because of the outside world and the inside circuit is always kind of working together to initiate a movement. If that goes awry and it again, I kind of use that term, it runs amok, then you have no control. But once you start changing the input from the outside, the thought is maybe it interrupts that signal. Maybe we are able to reboot that signal just enough that this bad thing that's happening is blocked in some way. So that's kind of the 5 different ways of looking at dystonia. I'm not sure folks that have been looking at or have been participating in a lot of these lectures have seen some of these things, but for a movement disorder doctor, these are the things that go through our mind when we see patients. So the big thing is, let's say you have a problem and you want to go see a physician or a provider. There's always this kind of nervousness because you want to get all your information out, but then are you getting the right information for the physician to figure out what's wrong with me? So I want to go over what, from my perspective, from a physician and a movement disorder doctor, what I think and what I need in order to deduce the problem. So one of the most important things that I want to figure out is timeline. I need to know the timeline, the sequence of events. If a patient tells me, look, when I was a child, when I was 12 years old, and when I was in school and I was holding a pencil, my hand would do some weird things. And I kind of got through it and, I try to ignore it. Now I'm an adult, but it's kind of getting bad and things are happening. That's important. That's important because that will trigger different disease process thinking for that provider, for that physician. Did this happen, for example? Let's say you were doing perfectly fine and you got into a car accident. And then all of a sudden, everything is wrong. That's important. Maybe you, heaven forbid, you had a stroke, or maybe you're dealing with cancer. I mean, these things, we need to know the sequence of events in order for us to characterize the dystonia. And then we go into the phenotype. Well, what does the movement look like? Typically, if you have the symptom in the office, a physician, a provider should be able to look at that and analyze that movement. As a movement disorder doctor, we are looking at movement that our patients are complaining about, but also movements elsewhere. We want to see if there are things that are happening away from kind of the problem at hand. So if a patient comes in and says, I've had patients say, I have issues with, my neck, but when I'm examining the patient, I find that, their hand was involved, but the patient wasn't aware. I mean, these are the things that we want to look for. And then, does anything modify movement or the symptom? Are there sensory tricks? Are there things that our patients are doing that are stereotypical for dystonia? I want to take this opportunity to kind of talk about worsening of symptoms. The thing about dystonia is that it's very sensitive. It's sensitive to the outside world. So if you have anxiety, for example, or stress, lack of sleep, depression, other medical problems that are going on, your dystonia will be amplified. It's not that the disease has gotten worse. Inherently, the disease may not have gotten worse, but your symptoms are 1,000 times worse. And sometimes this happens cyclically. So I have, every year, it's wintertime, all the symptoms are worse. All the symptoms are worse. And, I try to remind my patients, look, we expected this. Let's try to find compensatory things that we can adapt to get us through the winter. And so these are the things that we talk about. We want to know about active medical problems. Did you just have a stroke? Did you have a stroke 6 months ago? Did you get into a car accident 6 months ago? These are really important. Did you have, some job where you had to do something repeatedly and maybe you injured yourself in some way? These are the things that we want to think about. Number 5, we want to know about exposure. So things like, do you work on a farm where you're exposed to, industrial amounts of a pesticide? Or, were you in the army handling chemicals? Or some of our patients, they've struggled with mental health and they may have been given drugs, certain types of drugs, for a very long time or maybe a short period of time. And those things could trigger dystonia as well. And then, of course, family history. There's dystonia that have genetic kind of predisposition. So if you have family members of a very specific mutation, that can be passed on from generation to generation. So those are the things that we want our patients to be aware of. These are the things that we want our patients to share with our providers. And again, I recognize that time is very short with these visits. And so we want to get these at least, get to the bottom of these things. Let's see. It's not, well, me to turn. Okay, sorry. Not sure why sorry, let's see. Strange. Sorry, I'm not sure what happened here. Just lost control. Complete control over. It's going so well. And then I'm kind of stuck. What is this happening here? Uh-oh.
Want to tell him something?
Pause.
That. Okay, so this leads us to the testing. Once you give your story to the provider, maybe there are things that are missing. You have to fill in the gaps, and you fill in the gaps through various types of testing. And I know that you've read about it perhaps, or you've heard, patients get certain types of tests. I do want to emphasize that not all patients require extensive testing, okay? It is very individualized. Some things are very apparent. It depends on the history, depends on, maybe information that's already been given, maybe tests that you've already had. That's all you may need in order to get a diagnosis. But what's absolutely needed is the physical exam. I say that if you have garbage in, garbage out. So if you don't have a sensitive exam in order to gather the information, you can't output a diagnosis. And so in this situation, you have a movement that most physicians and providers can see, but they also need to examine the rest of the body. And so that's really important. And then I want to talk about the things below the physical exam. And I want to talk about why we may do these things. And like I said, you may not need all of these. You may need some of these or none of these. It just really depends on the situation, the type of dystonia, the timeline that you've given to the provider. And so it really is individualized. So maybe the doctor says, you know what, I need to run some tests. And the reason why they want to, let's say, run a blood test is because if you have certain types of vitamin deficiency, it can mimic dystonia, or it can amplify, or it can sometimes mask dystonia. And so that's something we look at. Metabolites, minerals. If you have calcium is actually really important in muscle stability and signaling. So if you have too much calcium or low calcium, that can manifest itself as dystonia or dystonia-like syndromes. The other thing that's really important is that sometimes a change in metabolites or change in these vitamin levels could signal other illnesses. And those other illnesses can also mimic dystonia. And of course, hormones. We talk about patients, you know, when we say hormones, we talk about things that are happening in the pituitary, hormones that are happening in the rest of the body. These things can affect how patients move. And sometimes we can be tricked into thinking that it's dystonia, or sometimes we miss it because hormones can change the stability of muscles, how muscles react. It can cause tremors and other types of active movements. So that's really important. Electromyography is sometimes used. I use it quite a bit. Again, I'm a bit biased because I do a lot of electromyography. I look at dystonia as a circuit problem. And so in order for me to understand if a circuit is working or not, I need to know the electrodiagnostic status of a human being. And so I use electromyography. Electromyography, for people who've never heard of it, essentially you get a needle. It's a probe, essentially a probe. Or there's actually what we call a surface electrode. So it's just a contact. So you could put the contact on top of the skin, and you can get some muscle activity. You can listen and hear and see muscle activity. But in order for us to be more accurate and we want to analyze each muscle, we have to use a needle, which is essentially a sharp probe, and we go in and analyze those muscles. And sometimes the way that I use it is I try to map out which muscles are involved. And when you map out the muscles, then you can look at that pattern and determine whether or not this is dystonia or whether it's something else, or what kind of dystonia may be elucidated by electromyography. I also throw in electroencephalogram or an EEG. The reason why we do this is because involuntary contraction of muscle can occur with kind of the seizures, as well as disruption of signaling in the brain. So, if you've ever heard of seizure simply is basically like a thunderstorm in the brain. And when you have that kind of thing going on the kind of the outside of the brain, the rest of the body has no choice but to contract. So we just mentioned that dystonia is involuntary contraction. So if you have a seizure, you're going to have involuntary contraction. So you could see where that can be confusing. And so sometimes we'll use EEG to delineate the difference. You may need genetic testing. We talked about family history. Again, depending on the timeline our patients tell us, this might be relevant. There are also kind of the ethical issue of genetic testing. So, I won't go into too much detail, but we try to be cognizant about kind of the utility of genetic testing. There's always been a debate in medicine about predetermining someone's life through genetic testing. So, it's kind of the question that we often, it's almost like a philosophical question. Do you want to know what's going to happen to you 20 years down the line? Or do you not want to know? If you knew, would it change how you behave? Things like that. So, genetic testing, even though in 2024, it seems like very commonplace, we still, I think physicians still struggle sometimes about the ethics of it. But we do think that it is a very powerful tool in some cases. A DAT scan, a dopamine transporter scan, and this is probably a little bit more exotic. We use dopamine transporter scans to determine whether or not you have some type of Parkinsonian syndrome. And Parkinsonian syndromes, and many of you may have heard one type of Parkinsonian syndrome called Parkinson's disease. And it is very common for patients with Parkinson's disease to develop dystonia. Now, where would I characterize that? Is that a secondary dystonia? According to my category, where you have one disease and this is kind of the consequence of it? Hard to say, but we sometimes use this if we think that there are other symptoms to suggest a bigger change or bigger issue. And then the PET scan. Again, you may have heard the term PET scan, positron emission tomography. The PET scan, what it does is that it looks at the activity of brain and it creates a pattern of activity. And depending on that pattern, we can figure out whether or not you have certain disorders. The problem with this is that sometimes the patterns are very murky. And a lot of diseases have patterns that overlap. So it is not the end all be all. And the DAT scan is the same, where if it's negative, it's not as helpful. If it's positive in a very specific way, it can be helpful. And then the cerebral spinal fluid. Now, this is an invasive procedure where you do a lumbar puncture, so a spinal tap, and we sample the fluid around the brain. Now, the brain is protected and covered with this fluid, this liquid called the cerebral spinal fluid. And that liquid actually goes from the brain all the way down to the spinal cord. Now, if we wanted to sample the fluid around the brain, we could either A, drill a hole through the skull and sample it that way, which is not something that most people want to do, or we go down kind of in the lower back where we can have access to that same fluid without having to go through the skull. And so that's why we have these lumbar punctures or spinal taps in order to look at it. Why do we do it? Well, we do it because there are certain autoimmune disorders, so immune disorders. You may have heard things like rheumatoid arthritis. Now, I'm not saying rheumatoid arthritis causes dystonia, but if you have an immune reaction, your body has become the enemy, or your body starts attacking itself. If it starts attacking, let's say, your kidney, we call it autoimmune kidney disease. If it attacks your joints, we call it rheumatoid arthritis. If it attacks the brain or the spinal cord, it can cause illnesses like multiple sclerosis, which then can cause secondary dystonia, right? And so all of these things we're thinking about when the patient is explaining the disease process. And so let's talk about the treatments. Now, you told the doctor what's happening. The doctor kind of says, okay, I think I know what's been going on. You did a bunch of tests and they say, you know what, I got a diagnosis for you. Now what? What do you do about it? Most of the time our patients are coming to see us because they're suffering in some way. Something is happening to the point where you say, you know what, nobody wants to go to the doctor. And we understand that if you're going to go to the doctor, there's something that's bothering you. It's either hurting you, it's driving you crazy, or you might just be worried, right? So you go there and we want to be able to get to a conclusion and then start talking about options. I want to mention, and I start with rehabilitation, physical therapy, and I should have said speech therapy as well. And sometimes this is not emphasized enough. I think physical therapy and occupational therapy is an incredible tool in helping our patients cope with dystonia. And it's a relatively non-invasive procedure. In fact, it is non-invasive, although some people say, well, if I have to work out and do all of this, it's kind of invasive in my life. But in terms of poking the skin and trying to get fluids and all that. It's none of that, but this can be very, very helpful. They can teach how to strengthen your muscle so that there's a compensation that occurs. I kind of explain that if you have, let's say, cervical dystonia of the neck, and if your muscles were like that of a 20-year-old, you could probably keep your head straight, in a more consistent manner than, say, if you were 90 years old, because your muscles have changed over time. But you can get that strength back, and that will help with compensation. Massage therapy is important. I used to say that massage therapy is the Beverly Hills treatment. And the reason I say that is because, unfortunately, massage therapies can be very expensive, especially if you do certified massage therapist. But it can be very helpful. The other reason why it's so expensive is because, to my knowledge, no insurance company actually covers that. I think there's like other countries where they may cover that, a type of massage therapy, but in most cases it's out of pocket. And so, but we know that it helps. We know that it helps, and sometimes we strategically recommend massage therapies for some folks that use botulinum toxin, and we know that it will wane at a certain time, things like that. And so I think therapy is really, really important. I do want to mention the last thing, which is orthotics. Therapists try to rehabilitate, but they're also a master of equipment, right? Equipment that can help with symptoms. And sometimes it means a brace. If you have dystonia of the ankle and the foot, maybe you need a foot brace or an ankle brace. These things we rely on our therapists to give us recommendations for that. And botulinum toxin. So I think one of the things that I did want to go through for folks is talk about the newest toxin, called Daxxify. And I will go over that in a little bit more detail, because I think most folks have not been exposed to that or have not had providers inject that. So I will touch on that. But in general, botulinum toxin has become essentially the first-line treatment around the world. And the reason why it works is that, we talked about how muscles contract on its own. Botulinum toxin causes botulism. So what is botulism? Well, it makes your muscles weak. It paralyzes muscle if you use a lot of it, or you got botulism, heaven forbid, in the community. And physicians have been using this toxin to our advantage since the 80s, when it was FDA approved for strabismus. And what the botulinum toxin does is that it knocks out the signaling. So the acetylcholine is a neurotransmitter. Now, what is a neurotransmitter? The way I describe neurotransmitter is this. Imagine the mailman. And in order for the mailman to deliver packages to lots and lots of people, they need a lot of mailman. If you only have one mailman, you're not going to deliver as fast or as much. So in this situation, if you don't have that many mailmen sending messages to the muscle is not going to move. Okay. And so what botulinum toxin is that it gets rid of the mailman. It gets rid of the mailman's ability to send that signal or send that letter. And so that's why it works. And, when we talk about botulinum toxin, we talk about the benefit, but the side effect, the thing that you don't want to have, is essentially the same thing. So we do want to weaken the muscle, but if you weaken it too much, that's not good, right? You want to weaken the muscle, but you, let's say, weaken muscles that you did not want to be affected, then that's also bad. So we often think about, again, the neck and the cervical dystonia. When we inject, we know that the laws of physics apply, meaning that you have a liquid going into a small area in the neck. And so sometimes that liquid, due to gravity or due to kind of the, the contraction of muscle, it can leak and go to places that you don't want it to go. And so these are kind of the benefit and the pitfall. They're one and the same. And the botulinum toxin is not a cure. We talked about the signaling, and it could be in all these little circuits around the body. The botulinum toxin touches none of that. And it's only kind of patching or dealing with a downstream effect of dystonia. And so we know that when you weaken the muscle, you're not getting to the heart of things, right? You're not going back to the actual problem at hand. But it still works. It still works because it can improve the quality of life. So we recognize the limitations, but it does work. There's another limitation. The other limitation is that it doesn't last that long. So when you get botulinum toxin, the kind of cycle that you typically see is that when you inject, it'll start working in about 3 to 7 days. It will peak at about 4 weeks, and then about 8 to 10 weeks, your symptoms will come back because the toxin will wear off. And so there's going to be usually a little bit of a gap before the next injection, and then the next injection occurs, and then you go through this cycle again. Now, it's not ideal because we recognize you may have symptom control for like 9 months out of the year, but the other 3 months out of the year, your symptoms may come back and you're dealing with the consequences of that. So we do recognize the limitations, although I will kind of mention the new toxin that may be addressing that issue. So transitioning to that, I wanted to talk about the toxins that are on the market currently. There's actually one more called probotulinum toxin, but I won't touch on that. It's similar to the other ones except the daxibotulinum. So these are the things that you've probably have heard, maybe your doctor may have talked about it. So I'll kind of tell you the brand names so that you're aware. So daxibotulinum toxin A, which is the newest toxin, which I'll go into a little bit more detail. It's called Daxxify. Onabotulinum toxin is Botox. That is the brand name. Abobotulinum toxin is Dysport. Incobotulinum toxin is Xeomin. And Rimabotulinum toxin, which is the only B subtype class, is called Myoblock. Now, the reason I bring this up is because I want to talk about daxibotulinum toxin, and perhaps many of you have never heard of this. This just came out a couple of years ago. It was approved for cervical dystonia last year. And so what makes it different than the other toxins that are on the market? So the reason why it's interesting and the reason why it's unique is that there is a synthetic peptide. So it's a protein that it's a man-made peptide that help enhance the effect of botulinum toxin. And I'll go into a little bit more detail how that works. But this is the first time in the history of botulinum toxin where a different compound in an injection maybe doing a little bit more of the heavy lifting. We're not just relying on the toxin to give a clinical effect. This other thing is actually helping things out. And so this is the first time this has occurred. The other thing to note is that it doesn't use human serum albumin. And the reason why this is important is because for some of my patients, they have religious restrictions on using human blood products or human blood components. And all the toxins that were on the market use a human blood component. Daxibotulinum no longer uses that, which is really good because physicians don't have to disclose that, you know what, when we inject you with botulinum toxin, there is this little component. The other thing that's actually important, and it's not listed here, is that daxibotulinum toxin doesn't use any animal products in the production. So many of the other toxins use sometimes cow or beef type of components in the production. And we kind of joke that the daxibotulinum is kind of the first vegan toxin. So there's no animal components there. The other things like non-refrigeration, that's not something that our patients have to worry about. And again, refrigeration and efficacy is these things physicians worry about. But for our patients, what they need to know is that if you do have, let's say, religious preferences on not using these products, using human components, this might be an option for our patients. So I want to go into a little bit more detail again about daxibotulinum toxin. So the reason why there's been a lot of talk about this is, again, because of this man-made peptide. And what it does is that it's this thing that help coat and protect the toxin. So if you put the botulinum toxin inside, let's say, a vial, and you put all this peptide in there, what it'll do is it'll encapsulate the toxin. It'll kind of protect it. And the unique thing about that is that it's charged. It's actually positively charged. And the reason why positive charge is important is because where it needs to go, which is the cell membrane of what we call the neuromuscular junction. So where the muscles are sending the signals, this toxin has to go and get inside that cell. Because it's positive, and it just happens that the cell outside is negative, it sticks. So when you inject somebody, instead of these other toxins where you may not have that charged component, it will stick on that cell for longer. And the longer it stays there, the higher the chance that higher concentration of the toxin can go into that cell. Ultimately, what that means is that you get a lot of bang for your buck. If you inject something, let's say with the other toxins, it might kind of get there, but it also kind of floats around. It might get washed out. This, when you inject it, it tries to stick and stay where it's supposed to be. So I'm sure there are, very smart people in the audience that can already think, oh, okay, wait. So does that mean that maybe the safety profile is a little bit better? And I'll get to it. And sure enough, it is. We're finding that people are having less side effects as a result. And this is kind of a illustration of what I described, or what I tried to describe. So you can kind of see the positively charged areas there in that toxin, and it sticks like Velcro or like a magnet to the nerve terminal, and allows a higher concentration to go in. And I kind of briefly mentioned the side effect profile, and we just published, a colleague of mine and we published a safety review data on all of the neurotoxins on the market. What's important here is to show that even though you increase the doses of toxin, it did not mean that you had more and more adverse effects. Like, for example, if you look at muscular weakness, you went from 125 units and you increased it to 250. The muscle weakness didn't actually go up. It didn't double, right? It actually went down, which is kind of strange. But so that is reassuring in terms of safety. So, just kind of as a summary, even though I kind of focused on the Daxxify because that's the newest toxin on the market, the one thing I do want to add is that it is the first toxin made in the United States. It's actually made about 5 miles from my house, so which is kind of interesting. But all toxins that are on the market currently do similar things. What they do is they weaken the muscle by getting rid of the signals that allow the muscles to contract. Okay, they're getting rid of the mailman. Because dystonia causes muscles to involuntarily contract, when you inject something like this, it reduces it and therefore improves the symptoms, right? So that's why botulinum toxin works. We'll transition to oral medications. Now, again, this may be discussed with patients, or sometimes, physicians may not have enough time to go over this, but I just wanted you to be aware of the different class of drugs we think about when a patient comes in with dystonia. So again, I won't have time to go through each detail, but you may have heard terms like Artane or Klonopin, clonazepam, or baclofen, or Xanaflex. All of these things are not cures. They do not, again, get to the heart of the problem, but it can significantly improve quality of life by either disrupting the signals away from, let's say, the brain, so like in your muscles, or it can work to disrupt signaling in different circuits. And that's kind of what we see. Now, the reason why oral medications, even though, I mean, who wants to get injections, right? But why is it that the oral medications are not considered first line? Well, because let's say you have a dystonia of the hand and you take an oral medication. These medications are not smart. It's not going to just go to that hand, right? It's going to go everywhere. And so even the problem at hand I'm sorry, no pun intended, is there. It'll go everywhere, including the brain. And all of these drugs will have an effect on your cognitive function, meaning the speed of thinking, your ability to think clearly. It can also cause side effects like sleepiness and tiredness. Okay, so there are repercussions. There's a price you pay. And that's why most physicians will opt to offer botulinum toxin, because if you inject in an area, it'll stay there. It won't go to your brain. Whereas these drugs will go there. And over time, these drugs may have other repercussions. There has been some report that long-term use of benzodiazepines, like clonazepam and Valium, you may have heard Xanax, it could increase the risk of dementia. Okay, so when we give these drugs, we are very careful. We try to make our patients understand that there's a price you pay for these. And sometimes my patients get frustrated because I'm not doling out these drugs, and I try to explain the reason I'm doing this is because 10 years from now, if you're not aware of who you are, then what's the point of having this son? It's not gonna help you. I do want to mention dopaminergic medication. So dopamine is another neurotransmitter, another type of mailman. So you could think of, if we thought about the acetylcholine, which is what I mentioned, if you thought of that as the United States Postal Service, you might think of the dopamine as like UPS. Okay, so it's another type of messenger. This is sometimes used in dopa-responsive dystonia. So there are subtypes of dystonia where dopamine replacement can be helpful. So in that situation, we would use drugs like this. And then I want to mention surgery. So if I were to go back, let's say 40, 50 years ago, I would have said, well, we have oral medications to help you, maybe. It's not going to go to the place that we want, but we have nothing else. And then the botulinum toxin came to market and said, you know what? Now we don't have to give you a drug that goes everywhere. We can really pinpoint the problem and try to help you in that way. But for some patients, even with all of that, their symptoms are not controlled. And so what we do is we go straight to the brain for patients where the dystonia is coming from the brain. So again, depending on the type of dystonia, this type of surgery may not be applicable. But for folks that have dystonia signaling that involve the brain circuits, something like this could be helpful. So what is deep brain stimulation surgery? So deep brain stimulation surgery is an implantation putting into the brain a probe that creates electrical stimulation or electrical field. So the way that the surgery work is and again, this is very simple explanation. It's a little bit more complicated than what I'm going to say, but we drill small holes in the skull and we guide a probe the size of an uncooked spaghetti deep inside the brain. And we typically put it on both sides, sometimes one side, sometimes both sides, depending on the type of dystonia. And by turning on electricity in the brain, we can interrupt those aberrant or weird signals, the signals that are not supposed to be there. And we can block those signaling. And so we would offer these types of surgeries for patients who have, let's say, no response or little response to the treatments that we have given. And the quality of life is so bad that patients are willing to do brain surgery. Now, obviously, it is brain surgery. There are risks. There is risk of bleeding, infection, stroke. Anytime you go into the brain, stroke is a risk. So we don't take it lightly when we recommend something like this. But this has become an option for our patients. And it's been an option for over 25 years or so. Okay. I want to show a video of a patient that have dystonia of the right arm. So you can kind of see the difficulty because of the involuntary contraction. You can see the right arm, very difficult. Just a big challenge to even eat. And so you can imagine how bad that is. Now, after the simulation, after interrupting those signaling, it's able to write.
Start in the center.
So, you know, I do want to mention, you know, I went through the three big types of interventions and then all the rehab. I want to talk about why sometimes my patients are frustrated and even physicians are frustrated in terms of treatment options. We wish that there were more options, okay? But there is a problem. The problem is that we do not have good disease models for dystonia. The reason why that is because I showed you all those circuits that I named that you don't have to remember. Dystonia can happen in any one of them. And a lot of the times, I know there are ethical considerations of what I'm about to say, but typically when we do research, we have to use animals sometimes, okay? And we can't replicate all types of dystonia in animals, whether it's mice or anything like that. And so it's hard to find treatments when you can't replicate the disease. And we can't test it on humans, obviously. That would be unethical. So we have to find another way. There are certain scientists and physicians. I worked under a physician named Terry Sanger, who's a bioengineer, and worked in his lab. So he's looking at creating disease models through actual computer boards with robots. And so he's trying to mimic dystonia in that fashion to see how can we disrupt that signaling? How can we fix that circuit? How do we reboot the system? And then the other problem is that when, again, this is kind of one of the frustrations is that my patients always ask like, oh, is there something new? Is there something else that we could use? A lot of the studies and a lot of the research are trying to address symptoms and not the cause. And again, it's hard because we can't replicate that disease model very well. So how can you create a cure or a treatment that address the cause of dystonia? So again, you know, every year there are a lot of clinical trials, but vast majority, if not all, just address the symptoms. Okay. I do want to mention stem cells, okay, because inevitably everyone kind of wants to know about stem cells. For every disease, my patients have always asked about stem cells. Stem cells, even though maybe in the media it's been portrayed as this thing that's going to cure everything, that's not how stem cells work. Okay, stem cells can potentially become theoretically any type of cell in the body. And in the last several decades, when we have tried to use stem cells for treatments, stem cells can become whatever they want, but they will often become cancer cells, right? So yeah, they can be anything, including cancer cells. And so that prevented a lot of the research. It created a problem. Now, we are looking at components of stem cells, and we are looking at parts of it or manipulating in such a way that can help some of our patients. But I just explained to you that the problem with dystonia is a signaling problem. So how can a single cell, let's say, that function in one way somehow fix the entire circuit? Okay, it's probably not going to be this way. It's not going to, our treatment with, even if a stem cell treatment came about, it's not going to be us like injecting something and all of a sudden the circuit resets. So I don't have a lot of hope right now that stem cell is going to be in the near future a treatment for us. Transcranial magnetic stimulation, another thing that a lot of my patients bring up. This is a way to almost disrupt the signal, much like electricity. In this situation, you use magnets. Now, the problem is that we haven't seen long-term efficacy, so it's still in progress. Ablation. Ablation is just a fancy word for saying destroying, okay? It destroys something. And you can destroy let's say if you have dystonia in the hand, you could potentially destroy the nerves that are causing that contraction. But you can already probably think about the problem. So if you cut the nerve, you can't use that hand. But it is technically an option. Central ablation, so going into the brain. Instead of us putting a probe, can we cut out a piece of the brain and try to interrupt? That's what we did a long time ago. Used to do that in the 1940s in the United States. And then there are feedback treatment wearables, like you have like electrical stimulation in the hands and things like that. And unfortunately, most of those don't last long in terms of efficacy. So these are some of the things that you may have heard. So I want to really talk, and I know I'm going over and I apologize, and I do want to make sure that we have enough time for discussion, but I want to talk about navigating healthcare. This is really hard. And personally, even though I'm in the system, I feel the pain of navigating healthcare systems. And there is no healthcare system that is perfect. And it doesn't matter where you're at in the world. There are always pitfalls. There are positives and negatives of every type. But there are common themes in healthcare that you need to be aware of so that you can navigate that easier. So I want to talk about insurance companies. Now, again, full disclosure, I'm part of Kaiser-Permanente. I'm not here to say Kaiser is the best, okay? That's not what I'm saying. You need to pick the insurance company that is right for you. Now, if you're healthy, perhaps it may just come down to cost, right? So how much does it cost? Money is really important. In the United States, where you have to pay out of pocket in most situations to cover the cost of healthcare, picking insurance companies, sometimes it's like, well, random, or you're forced to do it because you work for a company that offers XYZ. But when you are picking something like an insurance and you have dystonia, you need to be aware of the type of services that will be advantageous for you, okay? And so what I usually ask, if my patient says, oh, look, I'm moving somewhere and I'm going to lose this insurance, I try to counsel on how they could navigate this. And I just say, look, you know that you've been getting botulinum toxin, Botox injections from me. So you're going to have to continue that with the other insurance. So you need to be able to go there and start looking at who's in the network, who can provide the care, and then try to choose, in a strategic way, which insurance might be helpful. Now, again, I know there are cost limitations, and so sometimes you're forced to do certain things, but be aware that you may need these types of services that I'm going to go over. So you need a primary care provider. And sometimes my patients have what they call PPO. So essentially meaning like you could choose to go anywhere and you may bypass certain types of therapists. I say, do not do that. Do not do that. And the reason why you need a primary care provider is because that, things like dystonia can be highly sensitive to other active medical problems. So even though you might have dystonia, I'm sorry to say, it does not exclude you from other illnesses. And those other illnesses need to be facilitated by the primary care doctor. So when my patients switch insurance or they move somewhere, I say, the first thing you need to do, even before you get there, is to figure out, get a name, figure out who your primary care provider may be. That is really important. And the reason why it's important is because in most situations, that person is going to be able to refer you to a neurologist. Okay. And you may not know in a new environment who the neurologists are, right? So you may not know where they are or, who's available. So this will be a way in. So this is kind of the beginning. Now, beyond that, the neurologist in some areas may be able to handle all of it, okay? There are very, very smart neurologists who have been trained in movement disorders who may not call themselves movement disorder doctors or neuromuscular doctors, but they can handle dystonia and the treatment of dystonia. But sometimes you need, let's say, additional help, or things are not working the way it should, and you may need a little bit more of a subspecialist who can do things. I put in a neuromuscular specialist here because sometimes it's overlooked, but neuromuscular specialists, many of them will do botulinum toxin injections. So in areas where you may not have a movement disorder doctor, and I recognize movement disorder doctors are not available everywhere, a neuromuscular doctor can most times perform all the toxin injections and actually provide really good, really sound advice about dystonia without being a movement disorder. So you need to be aware that these types of subspecialties exist and you may need to utilize it. Again, going back to the insurance, figure out, are these people in the network? Are these people available to you should you need it? Okay. You also need that primary care doctor because you may need that rehab. We mentioned the rehab, how important it is. These are the folks that can help you. And then psychiatry and psychology. I briefly mentioned anxiety, stress, right? Depression, amplify symptoms. And psychologists may have, techniques. We always hear about mind over matter. It really will. It really does work. And if you have symptoms, sometimes doing things like biofeedback, cognitive behavioral therapy, things that psychologists can guide you on can actually help with symptoms. Sometimes it's better than drugs or toxins. Some patients want the quote unquote natural way of managing things. This would be a path, the physical therapy and then psychology or psychiatry. Okay. And then lastly, if you need a neurosurgeon, is there someone that is fellowship trained in these types of surgeries for dystonia? The subspecialty for neurosurgery that deal with deep brain stimulation surgery is called functional neurosurgery or neuromodulation. The surgeons that I work with, they have been subspecialty trained and they are experts in doing DBS for dystonia. And then you need to know the out-of-pocket costs, right? Money is a big thing. It is important when you're trying to get care. It stinks sometimes. You have to deal with it. You have to understand that there's copay for medications. So if you're picking insurance or insurance tier, figure out, you can ask the folks that work for that insurance company. Was it going to cost me? Because my doctor in that other network prescribed this, this, and this. What's it going to cost for me to continue that? There may be copay for the toxin, but not just the toxin. Depending on your insurance, you may have to pay for the toxin and the procedure itself. Okay. And sometimes, again, I've had folks that get surprised, say, wait a minute, what is this? What is this fee here? Depending on the dystonia, not all dystonia is FDA approved for toxin. So most of the time, and that's actually majority of my patients, we have to do off-label injections. We may have been doing off-label injections for 30 years, but it may not be FDA approved. The reason why that can be a little bit of a problem is that if you have to get authorization from an insurance, they may not authorize it. So again, you need to be aware whether or not, maybe before signing up with insurance and say, hey, look, my other doctor have been doing this. Is this going to be covered? Is this very specific thing going to be covered? Okay. If you do deep brain stimulation or any of these called destruction surgery, ablation surgeries, there's going to be a copay for surgery. Deep brain stimulation devices run on battery. Battery replacements can cost money depending on your insurance. These are the things that you need to be aware of. And then walkers and orthotics, durable medical equipment. Equipment may cost. There are some people, depending on the insurance, it may cover it. It may not. And then psychiatry and psychology therapy. And this is a problem around the world. There are not enough psychologists and psychiatrists. And sometimes insurance companies will cover a certain amount or this type of psychology. So you need to be aware of the costs. Okay. And so I usually end with this, where I say, look, in a perfect world, someone with the knowledge in navigating healthcare should be there holding your hand, helping you. But depending on where you are, what situation you may be in, or what part of the world, you may not be able to do that. You need to be able to take charge of your care. You have to be proactive. And care has to be individualized for you, right? Because there are a lot of permutation for dystonia. Nobody can say, look, everyone's going to be treated in this exact manner. Listen to your fellow patients. Know the good and the bad. Listen to different procedures and say, hey, you know what? Listen to patients who say, this is the best thing since sliced bread, but also listen to the patients say, this is the worst thing that has ever happened to me. And then I bring up this kind of intangible and non-scientific gut feeling. So I usually say, look, I'm going to tell you a bunch of things. And if your gut says, hey, you know what? I don't think I'm in line with what the doctor is recommending. Something is telling you that it may not be right for you. And I tell my patients, look, if you feel that way, I will again try to make my case, and I will do my best to make my case. But even after that, you feel uncomfortable, don't do it. Don't do things that are not comfortable for you. And so I know that's not really scientific, but I think that is sometimes important because you know your own body. And that's the end. I'm sorry I went over. I think this is a great time to start answering some questions.